All right, good afternoon, everybody. Welcome to this week's session. We're going to go ahead and get started. This week, we're joined by our Head of Pharmacy Services, Derek Taylor. As with all things healthcare, there's been lots of changes over the last couple of years with pharmacy and prescription billing. And today, Derek is going to shine some light on what's new and what you need to know. So let's get started. Welcome, Derek. Happy to have you back.
Thank you, Kate.
All right. So what billing issues are you seeing that typically go unresolved and result in those dreaded write-offs?
So I'm kind of in a unique position in that we're in a lot of different pharmacies. And so we can kind of see the way that looking retroactively, we can look and see where those different claims originated, and we see different pharmacies handle them a little bit differently, and the resulting in how many end up in write-offs or not. The most common area that I see is when you have new admissions that come in, and especially the ones that come in after hours. You don't have your billing department there to help make sure that you have the right payer, the right pay status on the patient. And there becomes this need to make sure to get the medication to the patient, but there can oftentimes be a delay, or if it's a Friday or on a weekend, it could be a delay of 2 or 3 days at least, until we're able to go in and confirm the billing payers and figure out based on the payers what's covered, what's not. And while most of the time with the Part D plans, they will give an emergency dispensing on some of those medications, that requires extra work and getting those addressed. And so oftentimes those fall through the cracks. When after those initial admissions come in, we'll get the medication switched over, we'll get the right payers on board, but a lot of that initial dispensing ends up not getting covered. The other area we see is occasionally on the rejected claims on the high dollar or non-formulary medications. The ball gets dropped somewhere in the pharmacy end. And so, the label gets printed, the med gets dispensed, but payment hasn't been confirmed before it goes out the door. And that's really hard to then on the back end get payment on those. And so a lot of those high dollar prior authorization medications, if they go out the door before that gets addressed, a lot of times they end up in write-offs.
Got it. How are you seeing that being handled successfully?
Yeah. So I think on the front end, the determination of how much is done by the order entry team with regards to billing really can have the biggest impact that I see. Very large pharmacies are able to staff a billing department person into the evenings to help cover those later admissions. But a lot of pharmacies don't have that capability, and the alternative to successfully handle that is by doing some increased training with your order entry team on the basics of setting up the patients. So meaning teach them how to do an E1 check. Most practice management software does have the ability that if you put in the patient demographic information, that you can do the E1, the eligibility check, and it'll populate if they have a Part D plan, or if it's a lot of times most state Medicaid plans interface with that. And so that way you're at least starting with a payer rather than starting just private and just, billing, generating those bills. And then the second part to that is when you then are submitting those initial claims after hours, to be able to train your order entry team on a few of the basic rejections, because there's quite a few simple ones that you can catch on the front end before they go out. So if it rejects that it's a prior authorization or that it's non-formulary, right then before dispensing the medication that you're not going to be able to get paid for, you can have the pharmacist call and change it and get those addressed on that end. So that I think that part of it in helping cross train, instead of having strictly the billing functions only being done by the billing department, to help cross train those staff that are there after hours, nights, and weekends on those basic functionalities, and that'll really keep you from avoiding a lot of those charges. The other thing is you really need to have a clear workflow for the new medications that come across that are high dollar rejected claims. And they need to have it where that workflow escalates them. It needs to go to the pharmacist to make that clinical decision, and or we'll talk a little bit about it today, but collaborative practice agreements for a lot of the common formulary switches really can help as well. If you have established relationships with the prescribing physicians at the different nursing homes and have standard collaborative practice agreements on, the 5 or 6 most common medications to switch on our end on their behalf, those can all be done upon admission, quickly and easily on our side. And then the patient's getting the medication that they're going to get. There's no, tracking down prior authorizations or retroing and trying to get payment on the back end. So having, confidence that if something is not covered, not paid, that it's going to be escalated and handled with more urgency, and that the ball won't be dropped there. To the point where, if what happens far too often is the label gets printed, it goes out the door, and then the billing office is trying to track down why it went out, and you're not going to be able to chase that down. So making sure you have that the lockdown workflow where no one's generating labels by accident or to get it out the door, that it all goes through a central, usually the pharmacist that's on there will be the one that's ready to make those formulary changes or make those high dollar decisions, to really keep the pharmacy risk as low as possible.
What about denials? What are you seeing in terms of denial trends? What the most common denials are that you're seeing right now?
Yeah, so obviously formulary denials and changes are all too common with all the Part D plans, and every year we get new ones and new changes. And it seems like the formularies, the state plans will change up as well. So familiarizing yourself with those, and oftentimes, the simple, if we're talking about the simple denials, things like quantity per days, quantity per dose, DAW codes, certain simple denials like that are easy to mitigate. They're easy to watch for. Or if you're, for example, getting early, refill too soon, a lot of those, there should be a really simple process to determine was that refill too soon generated on our side, or is it a refill too soon that is coming from a different pharmacy, or is it a refill too soon because the patient was discharged, meds destroyed and readmitted. And so, within those different cases, there should be a simple, a clearly defined workflow on how those should be managed. For example, on the ones where the patient's being readmitted from an earlier discharge, some of the insurance payers will allow a submission code that you can resubmit, or you do a call to the payer and get that authorization and get those redone. But a lot of those are ones that you can handle on the front end that you wouldn't necessarily want to burden your billing team with. And then, things like early rejections from cycle medications, because we're running and prepping cycles, 5-6 days ahead of when they're going to be administered. Those are very common. And so having your clearly defined process on cycle early refills or those kind of medications can really, help. Those are such common denials that you're going to see.
Any tips on avoiding those?
So I guess I kind of went through some of that as well. Okay. So, I think, being aware that when you have a patient that's coming back in, and they were discharged 2 days earlier, and you sent, on the first admission, we sent a 30-day supply 10 days ago. Knowing that it's going to reject and making that phone call right then, or doing the override codes. And also on the quantity per day, quantity per dose, on the topicals, just being, recognizing that you can't just put a low day supply, because a lot of times that will trigger the overuse. And I like it when pharmacies have very clear order entry day supply rules on inhalers and on insulins, calculating of insulin quantity per day and quantity per doses, or creams and lotions are always a hard one, because you don't really know how big the surface areas are or how long that tube's going to last. But have it be where, for example, a protocol where on the first refill, to adjust the day supply, reflect the interval since the first dispense. So if you're sending a topical that originally you put in for, let's say, a 10-day supply, and the refill lasted 30 days, maybe bump the quantity per day out to 20 or something, so that way you're trying to be as accurate in calculating, on the things that are not as easy to calculate, like topical administrations.
What trends are you seeing right now in terms of prescription billing?
So, regarding the tech, kind of the looking at the where they're not getting paid, or how much of the billing team is dependent on the nursing homes. I'm seeing a lot of previously, with regards to like census and admissions, the DONs and the nurses would send in, handwritten, quickly populated forms that would go to email or fax, and the frequency of them coming across was irregular, and they'd each use their own abbreviations, and it really has made it difficult for the billing team to really know on each patient exactly what their status is, and how those are being handled. And so I've seen the focus on training the nurses, training the DONs and the staff as to how them helping get us this information really helps them. The nursing homes want to have the best prices and not have non-covered meds going out, and they want to have their bills nice and clean at the end of the month. And when we are able to get that information in a clean, regular manner on the front end, it really helps, on that end. So I've seen a lot of trends there on with regards to trying to get that. I mentioned earlier, I've seen a lot of the collaborative practice agreements, or where at this point we've dealt with so many Part D plans having their preferred, SSRI, or their preferred PPI, or their preferred, whatever drug class, insert drug class, and the physicians just being stuck in the middle all the time, month to month, almost switching back and forth to different formulary medications, which are very similar, right? And so with having those already defined in the collaborative practice agreement, you're not even having to bother the physician, right? The pharmacy is able to help make those changes on their end, send the orders over, and so it's it's legal, it's in the patient's best interest, but really trying to lift the load off of the physicians. So I've seen a lot of kind of moving toward those in the areas in long-term care pharmacy where you have your good established connections with physicians that are the house doctors, who are open to that value. I've seen similarly a lot of increases in coordination with prior authorizations as well, where there's always been a bit of a disconnect with the sequence of who's going to do what within the prior authorization process, but I'm seeing a lot more coordination and collaboration with the physicians and the nursing homes on behalf of the patients as well.
What about technology? you're starting to see that play a larger role in terms of pharmacy billing?
Yeah. So it's I think the biggest change that we've seen is the transition of EMRs. That as EMR software has advanced and added additional features, and it's a pretty competitive marketplace. The outcome is there's now more drug order information and prior authorization information or billing information that's accessible in there. And as these EMRs are creating, the API interfaces with the practice management software, that's really facilitating pharmacies getting orders electronically, which also includes the billing, like for example, if we're switching drugs or switching or updating orders, so we can even do a push-pull within those EMR systems. Additionally, we have technology advancements in things like Cover My Meds, which really has increased their game in allowing it to be a shared workflow tool. Whether it's the patient or the pharmacy is initiating the request, we can populate the information that we have in our system through, most practice management softwares now, or most pharmacy information systems now have API interfaces with Cover My Meds. So I can sync up and pull in all of that general demographic information. And then when I send it forward, I can share that directly with the prescribers, who can fill in the clinical information and push it on their end. And I can then Cover My Meds see that it has been submitted and watch for the denials. Kind of that technology is helping in making it a much smoother on the prior authorization billing side as well. And then EMRs also are facilitating electronic census and billing information, which, like I mentioned before, it used to be handwritten, and there's still some nursing homes that do handwritten, but at this point now, the nurses are doing it within, most of them within their EMR, and the pharmacy can just generate reports, or they can auto push reports of the census information with the billing information tied to it to the pharmacy, and that can come come in on a much more routine basis and really ensure that we're putting in the patients from the get-go and each day under the correct payers.
Great. So let's switch gears a little bit and let's talk about prior authorizations.
Sure.
What is the appropriate role that pharmacies have in terms of prior authorizations?
This is a very interesting one in that, historically, the pharmacy really doesn't have a responsibility on priors. The patient and the doctor should be working together, right? But inevitably we're stuck in the middle, and we've gotten to assume a role of trying to help facilitate that. So we're working on behalf of the patient as well as doing what we can on behalf of the physician. To what extent we do both of those roles, like different pharmacies will be more aggressive than others. But I think kind of if I could say a sweet spot is, I think the recognition that something requires a prior authorization, the pharmacy should, do the initial troubleshooting of, is this truly a prior authorization, or is there an alternative medication we should be, that needs to be tried and failed first, and notifying the escalating that and getting a change in medication if needed. The second is, if it is something that does truly need a prior authorization, that we can go in, with that, as mentioned within Cover My Meds, or using, that setup established relationship with the doctors, to where we can find the correct form for the correct payer. We can populate the drug and patient information on behalf of the physicians and get that to them, so that that they're really only left to handle the clinical role, that of providing the doctor's notes or labs, or the justification for the request, and submit that request. And then on the pharmacy side, we can also follow up with it. So that way, if it pays, we're good to go, we're good to dispense, and we can enter those parameters in our system and, request reauthorizations when those get expired. If it denies, we can look into the denial and figure out what would be the next appropriate step, and then reach out to the prescribers. So I think we really can play a vital role in helping the patients and the prescribers in this kind of long, convoluted process of prior authorizations.
What recommendations do you have in terms of ensuring that your billing is accurate and allowing for smooth audits?
Yeah. So, I talked a little bit about daily census. The end of month census process is, it's always a beast, but looking between different pharmacies and, there are pharmacies that are able to close out their end of month billing in 3 days. And there's other pharmacies where it's, 7+ days. And in comparing, it's none of them are able to do it overnight. But the pharmacies that are more have a quicker end of month billing, what I've found is that they've invested more heavily in the communication and training of their nursing staff to get accurate daily census information, and that investment, while it seems like you're losing time and energy trying to train, on the back end, it does definitely increase the speed of the end of month, because that you're doing a lot less changes. You're getting those things, the correct payers and the correct plans updated. And so you're dispensing under the correct plans. So when it gets to the end of the month, you're not having to retro nearly as many claims, which is really, a big part of it. But, making sure that those are, those are current really will help you have accurate billing on that end.
Any suggestions for reducing that end of the month billing chaos that providers struggle with?
So yeah, so for sure, getting the nurses to get you those on a regular basis, but making sure that your team is staying on top of those. Billers get pulled a lot of different directions, and when you're doing the live adjudications, and you're getting calls on people on their bills, and you're dealing with trying to get prior authorizations, you can be pulled in a lot of directions, and oftentimes the daily census and admissions gets kind of backburnered or gets put behind. But there is true value in getting it current every single day, to reduce the number of those corrections. And so it's, if you're, even though it takes a little bit, if you're doing that right at the beginning of the day and making sure those are done and current, then as the dispensing is going on, from that point forward until there's a payer change or, it's going to be accurate. So then when you get to your end of month, you're not going to have those. A couple other things is, a lot of times there's end of month processes of looking for patients that were put in at private and never updated. There are patients that, there are reports that you'll run to look for OTC meds that are, shouldn't have been billed because they're house stock, or they should be billed. Certain OTC meds should be billed to Medicaid because Medicaid covers them. Some of those reports, instead of just waiting till the end of the month to do them, you can run those during the week intermittently, and be cleaning those up as you go. And then again, it's the same kind of thing where if you catch those early, then you're not going to get refill under the incorrect payer that you have to then fix at the end of the month. So I think those are really, I think universally the pharmacies that have short end of month processes are very diligent and aggressive on daily processes and getting that information and training their nurses to get it right and keeping it current.
How can long-term care pharmacies minimize the pending Medicaid delays?
So yeah, pending pending it's its own beast. With pending Medicaid, obviously it's very state specific, but I don't think any state does a really good job of notifying the pharmacies when a patient switches. What we've found is quite a few of the clients will generate a pending Medicaid list maybe once a week, and go into the state website and just check each of the patients and see if their Medicaid is switched over. Typically doing it weekly or because a lot of pharmacies will do it monthly, or they'll wait until they hear back from the nursing home that's now approved, and that 2 to 3 or 4 week delay from when it actually takes effect. I mean, you're really just delaying your AR. You're sending more and more medications that are just sitting out there waiting, and you're not getting paid for them. And then it's more medications you're going to have to retro. So yeah, I think that's about as good of a solution, unless you do have a good way within your state to get alerted to when patients switch, when their Medicaid becomes, effective. But I'm not aware of any states that in which they do that well, because they'll notify the patient or the nursing home, but they're not good at notifying us. And so it's just like, every pharmacy deals with the big pending, number. And so I think making that minimal investment of checking them routinely can really help keep that down.
Awesome. All really, really good advice. Derek, any last minute kind of words of wisdom, calls to action, advice that you would give folks?
I'm a little bit biased. I like documentation and processes. And when I we're in a lot of different pharmacies, I do see that from a training and retraining perspective, that if you invest in documenting all of those processes, it does pay in the long run. I know a lot of pharmacies are like, I just don't have the bandwidth to do it, or they're always struggling with staffing. But I think part of that staffing struggle comes from, doing the turnover and losing the people that have that tribal knowledge, that years of expertise, and it literally just goes out the door with them. And so that's just my little 2 cents, that I think, whether it's order entry or it's billing or it's triage or it's, the accounting or payroll or whatever your processes are in your pharmacy, make sure that there is documentation going on. And even if it takes you a year to get all of the different areas documented, that is a good, worthwhile long-term investment.
Good last minute words of wisdom. Thanks, Derek.
Thank you, Kate.
All right, bye.